Okay, any questions on that, on those states, on resistance, on compliance? Okay, so we're going to move on to speak about the clinical significance of our respiratory volumes and airflow. We'll talk about the volumes and capacities. We'll kind of differentiate them. We'll speak about some more clinical things like pulmonary function tests. And then lastly, we'll talk about alveolar ventilation. So this is an example of a spirometer. Anyone ever seen or used a spirometer? Yes? Okay. So a spirometer helps to measure the lung volume, so the amount of air that's being moved in and out per breath. And then from those lung volumes, we can then deduce the lung capacities. So the lung volumes can be measured directly using this apparatus. So basically this person is going to blow, and that's going to cause a shift in the amount of air here, and the level of water will rise, which will change the reading that comes out in terms of the volume of air that's being moved in or out. Now this is a really old version of this apparatus. The newer spirometers are or digital or computerized rather, and they have computerized readings. But I think we do have one of these on campus, and they're kind of cool to play around with, okay? Okay, so from the lung volumes, we can then deduce the lung capacities. And so we'll speak about the lung volumes and then eventually talk about the capacities that we can deduce from those volumes. So a tidal volume is your single unforced breath. So I'm gonna have you guys actually kind of mimic this on yourself if you'd like, and kind of get a sense of this actual volume in your own physiology. So if you're taking a quiet normal breath, right? So sit still, take your quiet normal breath, you bring air in and bring air out. That's your tidal volume, right? It's usually about 500 milliliters. And that is without any force or any additional effort to breathe. Then we can talk about your inspiratory reserve volume. So if you take the deepest breath that you can in, that volume on top of your tidal volume is your inspiratory reserve volume. So the additional amount of air that you can move in on top of your tidal volume, that is your IRV. That's usually about 3,000 milliliters. So that's your most forced inspiration. Now, if you take a forced breath out, right, you may usually feel your abdominals engaging here, forcing all the air that you can out of the lungs. That is your expiratory reserve volume. So that's the additional amount of air that you can move out on top of your tidal volume. That's usually about 1,000 milliliters. And that's the maximum effort for expiration. And then your residual volume is what's left. Now the residual volume cannot be measured with a spirometer. It has to be measured with helium dilution, which is a technique for measuring this volume using a known amount of helium mixed in air and then deducing the value that way. But because the residual volume is what stays in your lungs, we cannot measure this, right? We have to actually move that air in order to measure it. So the other volumes we can measure because they're actually moving, but the residual volume we have to calculate using a more elaborate technique, okay? Okay, so from those volumes, we can then speak about capacities. And capacities are basically how we add and subtract and make deductions about the air that's moving from the volumes that we can actually measure. So we cannot actually physically measure the capacities, but we can simply add volumes together and come up with those capacities. So your inspiratory capacity is your tidal volume plus your inspiratory reserve volume. So that's all the air that you can move in, okay? Your tidal volume plus the extra air that you can move in a more forced inspiration. That's usually about 3,500 milliliters. Your vital capacity is the maximum volume that you can expire after inspiration. So after you take a normal breath, right, you take your most, after you take your most forceful breath rather, and then you completely expire all that air out. So the deepest breath that you can take, that is your vital capacity, right? And that's one of the most important lung volumes. That's all the air you can get in and all the air you can get out. That's about 4,500 milliliters. Then we can speak about the functional residual capacity. We talked about this volume already, but this is how we actually deduce it. And because it's a capacity, we can't actually measure it, but we can add the expiratory reserve volume to the residual volume, and we can conclude that that's your forced functional residual capacity. All right, so think about what's left in your lungs after a quiet breath. Think about you forcing as much air as you can out, that's your expiratory reserve, and then adding what's still left back, your residual volume, and that's how you can deduce your functional residual capacity, which is usually about 2,200 milliliters. And then finally, your total lung capacity is the volume of air after your maximum inspiration. So we simply add tidal volume, inspiratory reserve, expiratory reserve, and your residual volume, okay? And that's 5,700 milliliters. That's the maximum air that can be moved. Well, not moved, because we can't move residual volume, but the maximum air that is associated with lung function, okay? Your total lung capacity. All right, let's see. So we'll speak about pulmonary function tests, so how we can use the knowledge of those volumes and capacities to talk about different lung diseases. So there are two main lung diseases that we'll speak about: obstructive pulmonary diseases and then restrictive pulmonary diseases. Now, obstructive pulmonary diseases are usually things like asthma, COPD, and these are where we have an increase in the airway resistance, the examples that I mentioned earlier. These are patients or people usually have overinflated lungs, and I kind of alluded to that earlier. Because they have a hard time moving air in general, both in and out, they have what we call air trapping. So they trap a lot of air inside the chest cavity. This gives that barrel-chested shape, makes the chest become really expanded. And we also see functional residual capacity increased. Why would we have an increased FRC? What's FRC? Yeah, so I think I'm hearing it. It's what's left in the lungs after normal inspiration. And so we typically don't get these patients emptying what can be moved through the airway because of those obstructions that we talked about. So they have an increase in that residual capacity in the lungs. And then vital capacity decreases. Obviously, again, we're not able to move air in and out, so that volume will decrease as well. Restrictive lung diseases are usually where we have difficulty expanding the alveoli. This is typically things like tuberculosis that scars parts of the alveoli. We can see this with extreme obesity as well because of the compression of the thoracic cavity. And so these patients typically have decreased compliance, right? The lungs really don't want to expand. For whatever reason, there's different pathologies that can bring this about, but the lungs do not want to expand, to open up and accommodate air. And so these people have a hard time getting air in specifically. They can get air out just fine because there's no obstruction, but the compliance is where the problem is, and so they can't get air in as easily as a more compliant lung. So the total lung capacity decreases and the vital capacity also decreases.